Hi, I'm James Rippey and I'm going to talk about the emergency department difficult intubation pathway. There are lots of these pathways around. This is one we've developed that is hopefully as simple and straightforward as possible and should be on a chart on your wall and on your difficult airway trolley. It's very simple, and this middle line here is what it's all about. Start by preparing, try and intubate. If that doesn't work, try and bag, valve, mask, ventilate. If that doesn't work, LMA. Bag, valve, mask, ventilate your way out of that if you're unsuccessful again. But the next step is surgical airway. So very simple. Prepare, intubate, try and bag, valve, mask, ventilate. LMA, try and bag, valve, mask, ventilate. Surgical airway. The middle line. Intubate, LMA, surgical airway. Remembering that bag, valve, mask is our friend and can get us out of jail anywhere along the way. So, straightforward down the middle, but it's a bit more complex. Let's discuss it in more detail. The first thing you need to do is prepare. And you're going to prepare the patient, make sure their position, their oxygenation, their hemodynamics, all as ideal as possible. You're going to prepare your equipment, make sure everything you need for the routine intubation as well as if things go wrong is there and ready. Prepare your team, make sure all the staff you need are there, that they know their roles, that they know what to do if things go wrong, and prepare for difficulty specifically. We have an emergency department pre-intubation checklist which can lead you through this preparation phase, which we'll discuss in another little podcast. Once you're prepared, you intubate. If you're unsuccessful though, this is the time to call for help, and this chart will have the ED duty consultant and the duty anaesthetist numbers on them. Call them then. Don't wait until it's all too late, so call for help early. If you're successful in your intubation, you need to confirm placement of the tube with end-tidal CO2 as well as all the usual things. If you try and intubate and you're unsuccessful, this is where the bag, valve, mask is essential. Because if you can ventilate and maintain that person's oxygenation, you've got time. So from here, you try. If you're unsuccessful with intubation, you bag, valve, mask, ventilate, and if you're able to ventilate and maintain O2, you can have another go at intubation. We'll get to that. If you're unsuccessful, then you need to move on to LMA. But let's say you're successful, you maintain that person's oxygenation, you then get a second go at intubation. And so you do something different from what you did before. If you've got video laryngoscopy, this is the time you use that. You could try a McCoy blade. Hopefully you will have tried a bougie already. If you tried video laryngoscopy in your first intubation attempt, try it, but try it differently in your second intubation attempt. So if you've got a CMAC, use a D blade for your alternate intubation attempt. Do something different. Optimize things. Try a different strategy. You get a couple of goes, but I certainly wouldn't try more than 3 times to get an intubation, standard intubation down, because you're going to start causing trauma and things are going to get more difficult. If you've been unsuccessful, you try and bag, valve, mask, ventilate, try and maintain their ventilation and oxygen, and it doesn't work. Then there's not time for a second go at intubation. You try, you go straight on, and you put in a laryngeal mask. We go back to the alternate intubation. If you're unsuccessful on your second attempt there, you try and bag, valve, mask, ventilate, make sure they're maintaining their oxygenation, which they should do because we've already established that they can be ventilated with bag, valve, mask ventilation, and then you can put an LMA in. If that doesn't work, you can always try bag, valve, mask, ventilate them again, get their oxygenation up and good, and then you could try a second generation laryngeal mask like the Fast Track or Supreme. If your LMA is successful, you need to again confirm that you're actually oxygenating and that you've got end-tidal CO2. And if you've got an LMA in place, then don't try anything else fancy. Get the anaesthetist down. They can put an ETT in via the LMA, and they may use the Fast Track ETT, they may use fibre optic bronchoscopy with an Aintree catheter. There are lots of different ways of getting a formal ETT in through an LMA, and that's their territory. We need time to let them do that, but you've got your patient oxygenated and they're not going to die. So LMA, great, almost always. If you're in the very, very unlucky and bad place of failing to intubate, failing to bag, valve, mask, ventilate, and then failing to get an LMA in, that's when it's time to go to a surgical airway. And you can either try with a cannula, cricothyrotomy, and ventilating through that, and then Seldinger exchanging with a Melker exchange catheter and ETT kit, or you may use the scalpel bougie ETT technique. There's an entire separate podcast on the surgical airway and how to approach that, but you must take that step. If you can't intubate, you can't bag valve ventilate, and you can't get an LMA down, you have to go to the surgical airway. Obviously then, if your surgical airway is successful, you need to confirm placement and talk to ENT. And important things to always consider are, can I wake the patient? Usually in the emergency setting, we can't wake the patient because this is an emergent airway. There's either respiratory failure or they're not protecting their airway, and waking the patient's not an option. But if you can, do it. Can you get help? Try as hard as you can. Make sure you use the best technique for bag valve mask ventilating with 2 people, one supporting and using jaw thrust and supporting the mask on the face, and the other squeezing the bag. Use appropriately sized Goodell. Use dual nasopharyngeal airways. You might need to try a different operator to intubate the patient. Reposition the patient. Use external laryngeal manipulation. Bougies and Stilets incredibly useful, and the Frover ventilating bougie you can actually ventilate through. So if you get the bougie in and you can't railroad the tube, you can ventilate through that. And different handles and blades are on the difficult airway trolley. So think about those things, look at this poster, and don't be scared to take the next step. Prepare, intubate, try and bag valve mask ventilate. If necessary, go on to LMA and surgical airway. Become familiar with this pathway, let it be your friend, and good luck.